Well, thank you, Ryan. And I'm Cheng Li, Director of Brookings John L. Thornton China Center. I'm honored and humbled to moderate today's second panel. Before introducing the next group of speakers, I want to convey my heartfelt appreciation to the terrific speakers on the first panel. Your expert insights and professional dedication have been vital services to your respective nations, and indeed in the service of all nations. At this historical moment, the biggest humanitarian emergency of our lifetimes. The international community will surely benefit from the responses and the lessons of your countries. Now, our second panel is less country specific and more focused on prevention, treatment, and forecasting of the corona epidemic. We are so fortunate to feature three leading experts on these topics. The first speaker is Dr. David Ho, a Taiwan-born American scientist who is the founding scientific director of the Aaron Diamond AIDS Research Center in New York City. As many know, since the 1980s, 75 million people around the world have been infected with HIV. Of those, 32 million have tragically died. The rest have survived thanks to the remarkable antiviral therapy known as the AIDS cocktail, which was first developed by Dr. Ho in the middle 1990s. In 1996, Dr. Ho was named Time Magazine's Person of the Year.
The masks that they wear in public spaces should only be surgical masks and not
their voice. Now, just as David Ho is a household name across the United States, our next speaker, Dr. Zhang Wenhong, is a household name in China. Dr. Zhang is professor and head of the Center for Infectious Disease at the Huashan Hospital of Fudan University. Since the early days of the coronavirus outbreak, Dr. Zhang has served as the head of the experts team for medical treatment of coronavirus patients in Shanghai. He has emerged as a leading expert on prevention and the treatment of the virus. He has earned substantial media praise in China, perhaps next only to Zhong Nanshan, another legendary figure in China's battle with SARS in 2003 and the coronavirus now. Last but not least, Dr. Chen Jian is the founder and the president of CreditWise Technologies, trained in engineering, computer science, and mathematical modeling in both China and the United States. Dr. Chen's specialization includes application of state transition metrics modeling to infectious diseases. Since the coronavirus outbreak, he has worked very closely with many leading scientists and doctors in the field, including both Dr. Zheng Junhua from the previous panel and Dr. Zhang Wenhong on this panel. Dr. Chen provides timely data analysis and matrix forecasting on crucial issues like infection peak time, patient distribution, and mortality rate in various locations. Please join me in giving a warm virtual welcome to our three outstanding panelists. Now let me turn to the first speaker, Dr. David Ho. Over to you.
Thank you very much, Li Chen. It's a pleasure to participate in this online symposium. I think everyone knows that the global pandemic now has infected over 1 million individuals with 55,000 deaths worldwide. And the United States now account for about a quarter of the caseload and accounting for over 10% of the deaths. And we're still in the upswing of this particular epidemic. I just want to give you a view of the situation here in New York State and New York City in particular. Yesterday in New York State, we had approximately 9,000 new cases. So we are the new Hubei, and we're not even done with the epidemic yet. In New York City, yesterday, we reported 5,000 new cases. And so we are the new Wuhan, and the numbers are still continuing. And it's hard to believe that it was only 1 month ago that we saw our first case. Now in the hospital outside my window, 5 floors of a major tertiary referral hospital is taken over by COVID patients. Our hospital has become an ICU hospital to a large extent. Almost all the usual ICUs are now occupied by severe COVID cases. And we have not even reached the peak. Let me just tell you that of the swabs that are coming from the nose or throat submitted for PCR testing, about 2/3 of them are positive. Of course, this is a reflection of the inadequate testing, and testing is preferentially administered to the sickest patients. But it is very difficult to imagine what's going on in the hospital here. We have carnage that's unprecedented. Now, in the US, we are seeing wave after wave of infection hitting different regions, as you know. The first wave hit the West Coast, and New York followed shortly thereafter, with New York becoming the epicenter of the epidemic in this country. And this now is followed by waves sweeping through cities like Detroit, New Orleans, Chicago, and rest of Middle America. I think the problem is that many of the regions in the US are not proactive. They are only reactive when problems appear. The attitude seems to be that this is someone else's problem, but yet the virus spares no one. And my concern is that, let's say California, which was the first to implement more draconian measures to control the epidemic, let's say it flattened the curve in the course of the coming months or two, but its neighbors, Arizona, Nevada, and others, are still struggling with waves that occur much later. How is California going to relax given the freedom of movement that we have in this country? And if you, in essence, I think we need to apply this sort of thinking not only to the US, but to the world. If we continue to let a lot of countries treat it as if somebody else's problem, the world cannot open up because our neighbors will be struggling with the infection. And so in many ways, we need global leadership to compel the world that we apply the same measures in synchrony. We need to do that together. In essence, we need to endure together, flatten the curve simultaneously. In essence, somewhat similar to what China did in late part of January. Of course, hindsight is 2020, but if we imagine the world having implemented shelter in place in late January, this crisis would be largely under control now, with a good chance for extinction. But that's not where we are. And yet there are too many places that are still treating it with great deal of complacency, thinking they would be spared. As I said earlier, the virus will spare no one when it comes in contact with a particular individual who's not immune. So I think there's a lot of talk about flattening the curve and avoiding the surge that will overwhelm healthcare systems. and that we must do, and it's being applied in many places, and hopefully a healthcare system that could absorb the surge of patients would manage to support patients better and have a much lower mortality rate. One thing we need to keep in mind, though, is that spreading out, flattening the curve means we're spreading out the infection over time. But the cases will continue to accumulate. So we need to extend that flat curve out much longer because the cases will build up unless science delivers a solution to treat or to prevent infection. And so I think for the foreseeable future, we have to plan on not seeing much of a scientific solution for the next year, and perhaps two. Now, there's a lot of talk about repurposing drugs that are already available and have already been tested in humans for other purposes. And yes, that we must do, and that already has been done to a large extent in China and Europe, and now beginning in the US. These drugs, some of them decrease inflammation, some of them treat the virus, but from the data that are available now, at best, they're going to be only temporary solutions. We need to launch a global effort to find new drugs, antibodies, and vaccines that are optimal for this virus, but also for this lineage of beta coronaviruses, because the next pandemic may not be exactly this virus or exactly the SARS coronavirus. So let me just tell you that from this, as a working scientist on this front, I'm inspired and I'm awed by what the scientific community has done. It has mobilized in a way that I have never seen before. A lot of laboratories have to shut down if they're not addressing the COVID outbreak, but some of them have very rapidly shifted to work on this problem, contributing some in mundane ways and some with very special ideas. And I would just tell you, there are already hits in the laboratory for new drugs that block certain enzymes of the virus, protease, polymerase. There are already antibodies that have been identified that could neutralize the virus and perhaps be used as either a therapeutic or a prophylactic. And we know that there are already vaccine candidates being developed by at least 20 companies, if not more. And several of them are either in the clinic already or will soon be in the clinic. And same with the drugs and antibody hits, those have been slated for entry into human testing within the next few months. So this is really unprecedented. However, starting testing doesn't mean they will be immediately available to address the pandemic, because the process of testing for safety animal, putting it into manufacturing, then with the manufactured product, you have to further test it for safety in animals, and then begin a series of human clinical trials, starting with phase 1, slowly with a few people, and then enlarging those studies to include more people and for longer duration of follow-up. So you could see this process of product development will take quite a bit of time, certainly more than a year, and if not 2 years. So we are contracting the process from typical 5 to 10 year drug development timeline and trying to contract that at least 5-fold, if not 10-fold. So that's what we're confronted with. But in the long run, I'm confident that science will provide a solution given the dedication now put in, not just by the healthcare workers, but by the basic scientists who are trying to find permanent solutions. So let me leave it there. And thank you, Li Chen, for the chance to talk.
But also hopeful remarks. We will certainly ask you questions. A lot of audience already sent questions. So we go to next speaker, Dr. Zhang Wenhong, please.
Yeah, Li Chen, glad to meet you. And I'm honored today to be here that have the chance to discuss this epidemic with Professor Hu together. And it's a good chance for me to share the Shanghai experience with the scientists and the clinicians around the world. So first of all, I just want to share some experience in our city, the big city with almost 30 million people, and in China, the experience both from Wuhan and Shanghai, totally different situation. So the Wuhan stand for a city with the outbreak of the disease, and in Shanghai, a big city with imported cases. So first of all, I just want to share some experience of Shanghai. Firstly, the first case of COVID reported in Shanghai was January 20th this year, and it is an imported case from Wuhan. And after 2 days later, the Wuhan announced its lockdown, and I think it's a good chance for us that stop the imported case from the epicenter in China. So several days later, Shanghai announced a top-level response to the major public health emergency. And we can see that after strong measures controlling the local transmission, and which help us to stop the spread of the disease. So Shanghai, in the end, stopped the spread of the disease very quickly. However, we can also observe that in the mid-March, the challenge for Shanghai now has turned to global imported cases. I think this is a second wave right now. I think this challenge is almost the same like other countries, just like Korea, Singapore, and I think the same challenge around the world. So today, lots of experience from other countries actually help us to face the challenge of the second wave in this plague. So actually, before we work for stopping the spread of the disease in Shanghai, one colleague from the United Kingdom, he published a paper. They showed the model that predicted Shanghai with 30 million people and lots of imported cases from Wuhan. They predicted that maybe almost 800,000 COVID cases will be in the end happen in Shanghai. And another model, they predicted that at least it should be 8,000 cases will be reported by mid-March. Actually, in the end, we just now only around 400 emerged in our city. So the key was the early control of the local transmission. I think this is the most important experience for us. The first case in Shanghai, like that in the United States, was identified on January 21 and 21st this year. At that time, Wuhan's lockdown suppressed most of the intercity traffic from Hubei province to Shanghai. Shanghai, in the meantime, immediately took aggressive measures to slow down the whole city, including canceling all gathering activities, suggesting all citizens to stay at home. I think these measures recently also taken by the United States. So meantime, it's very happy by us. We have the very long holiday in China. You know that it was Spring Festivals. So I think we were very lucky that we have a long duration to stay at home and without doing job outside. So furthermore, our city, the government extended the Spring Festival more than 10 days to 1 week more, thus allowing Shanghai's social distance to overlap the length of the 14-day incubation period of this disease. Therefore, if anyone really had a possible infection through intercalling and imported case, I think the time is fit. So our holidays. At the same time, although we stay at home, the city, so the grocery, supermarkets, hospital, banks, and other life necessary facilities remained open for the normal life. So you can see here, the Shanghai just slowed down, not lockdown. We keep our traffic, we keep our life necessity facilities, so everything remain normal. So I think this is a good tempo for us in the future. If we control the imported cases at a very early stage, we can keep our normal life and not lockdown. So after the outbreak, I think everything changed. So meanwhile, in our hospital, I worked in a comprehensive hospital with 2,000 beds. We do massive testing, and the Shanghai CDC, they traced every patient among suspected case. So, and now I will introduce to you how we optimizing diagnostic flow for COVID diagnosis. In Shanghai, we for almost a network of 120 fever clinics, and also we added more 180 fever sentinel hospitals. So this is a big network that will help us to find suspected patients. We do the test for every suspected patient we found without money. So everything is free. We do it very quickly. So this helps us to find the people timely and quarantine the suspected case and quarantine the close contacts. The timely diagnosis would lead to the timely quarantine and the broken of the transmission chain in Shanghai. In fact, the timely diagnosis protocol and the timely quarantine measure in Shanghai effectively stopped the circulation of the COVID in the city. This activity did not cause overwhelming impact on the normal citizen's life because we quarantine every suspected case we found and no spreading of the disease in our community further. The incubation time, we found that only in our city, only 6 to 7 days, and the mean onset hospital admission interval was almost 5 to 6 days, so very short. So therefore, all those methods in the end lead to early control of the local transmission in the community. And this is the key to stop disease spreading. In Shanghai, we can see that after the original imported cases, the local transmission were quickly inhibited, and therefore, that led to the control and the prevention of the epidemics. The overall mortality rate, because we have just several hundred cases here in Shanghai, so we have enough medical resource to keep our critically ill patient well cared. Therefore, in Shanghai, our mortality rate of the patient only 1% in the end. So in the end, we concluded that the key points of the medical and the health control in Shanghai and China is that we found all suspected patients and tested them and at least twice by CDC. And so therefore, we increased the sensitivity of the PCR to find the patients. All nucleosides and the treatment are free in Shanghai. All diagnosed patients should be admitted to designated hospital, just like my colleague Junhua Zheng mentioned that in Shanghai, we gathered all power in our city together to treat the patient in the designated, because we only have almost 400 patients. So our medical resource recently, we know that it's very enough. If we have much more patients, I think our ICU beds is not enough. All the close contacts of the diagnosed patients, we traced and quarantined for 14 days, and all close contacts of the diagnosed patients will receive the RT-PCR test recently. So all these jobs are done by the CDC colleagues. So I think all my presentation today here, and I will thank for your attention. It's actually, as Shanghai and China, we just went through a pretty dark moment but however, now the plague now still spreading in the world. I think we should work together to fight the disease. And I hope that the experience here today, I will study the experience from other countries to face our second wave. And our experience in the first wave, I think also can be shared by other countries. Thank you.
Thank you, Dr. Zhang. As a Shanghainese myself, I certainly admire and appreciate your wonderful work in this battle. And really thank you for sharing your insights, your experience. Now, next speaker is Dr. Chen Jian, please. Chen Jian.
Can you see my screen?
Yes, yes.
Okay, thank you. Thank you, Chen, for this wonderful opportunity to share some of the modeling experience I've had with both Dr. Zheng Jinhua and Dr. Zhang Wenhong. So today I'm gonna introduce the tool I use. It's a transition matrix model. I found it to be a very powerful forecast tool. So first, I've had some 20+ years with financial modeling. My experience with COVID-19 is only 60 days. Well, it seems that there's some similarities, so I can utilize my skill set to forecast COVID-19. So what is forecast? Forecast is basically to provide certainty in the world of uncertainty. So with good quality forecast, we can do better planning. We can do better planning with medical personnel. We need to know how many doctors, nurses, cleaning staff we need. We can do better planning with medical supply, how many ICU beds, ventilators, N95 masks. We can do better planning with biohazardous waste disposal capacity, and also with government and policy and business practice. And most importantly, in the darkest moment, people, they want to know where is the end of the tunnel. They want to see the light and the end of the tunnel. So how can a financial model be applied to COVID-19 forecast? So I'm not a medical expert, but I'm very lucky to have friends, very close doctor friends like Dr. Zhang Wenhong and Dr. Zheng Jinhua. So after consulting with them, I designed this flowchart to describe how a patient goes through the firstly goes through the close contact with an infected person, and then he will be put under medical observation. In China, generally, it's in a quarantine hotel for at least 14 days. And if he's tested positive, he will be identified as a confirmed case. If negative and no symptoms within 14 days, he will be discharged. So once he's diagnosed with confirmed COVID infection, he will, if he has non-severe cases, in Hubei province, they will be put under this Fangsang Shelter Hospital, which are large makeshift hospitals renovated from convention centers, stadiums, shopping centers. And if their symptoms are severe, they will be put into designated hospitals. And obviously, if their symptoms become critical, they will be put into ICUs. And if the treatment is not successful, they will die. And that is the worst case. And it is a final or end event for this transition matrix. But within this COVID-19 treatment, we can say a severe case can transition into a non-severe case, and severe case can transition into a critical case. And also the cases, the stages, there's certain level of dependency, so they can change between these cases. So if we look at this mortgage servicing flow chart, we can find a lot of similarities. So normal mortgage can move from a regular payment mortgage into early delinquency. And if it doesn't cure by itself, it can go into serious delinquency in the second stage. And that stage, they can go through a loan modification, which is very like the treatment. In the mortgage servicing industry, we actually call it treatment. So actually a person can self-cure or they can cure by loan modification. And if the serious delinquent loan, it doesn't get any treatment and it becomes even worse, it can go through a default. The default itself is also a bad event. So the purpose of mortgage servicing is very similar to the treatment of the virus. We want to minimize the probability of the bad event. So we conducted this forecast at the very beginning of February. And the very first, we were basically trying to forecast what is the turning point of this province. It seems that our model is pretty accurate during the month of February, which is a peak season for this COVID-19 virus in Hubei. So if we look at the number of peak active cases during the month of February, the actual number is 50,633. And in our forecast, under the cautiously optimistic scenario, the number is between 44,000 and 55,000. So the final number is between these two forecasts, and it's very close to the middle point. Next, we enhanced our model to predict the critical cases. So the actual critical cases peaked at 2,492 cases. And during, in our forecast under S2 scenario, our forecast is 1,986 to 2,484. So actually the critical cases is also very close to this range, only about 8 more cases compared to the second number. And the cumulative total cases at the February end is 66,907. Under our forecast, it's between 60,000 to 71,000. So again, the prediction seems to be pretty accurate regarding Hubei model. So after February, we learned a lot about this virus and how it can be controlled given certain level of preventive measures, both inside Hubei and outside Hubei. So we utilize this model and we put out forecast for other countries. This model is built for Italy. So from this model, we can see we built 3 different scenarios. S1 is our benchmark, which assumes very strict measures and very good compliance from the people. So the final number would be pretty low. And the second measure would be less restricted and there's more wide outbreak. So in the second scenario, it's only about 60% of efficiency of the first scenario. And in the last scenario, which is S3 scenario, it's another downgrade of the efficiency. It's only about 60% efficiency of the second scenario. So only 36% efficiency of the first scenario. We tested the model on March 9th, And at that time, we predicted that Italy's situation is very likely to be S3, which means that it's going to be relatively pessimistic. So today, about 1 month later, when we look back, we find that the model has performed very well. The peak time for Italy until now is March 22nd. And in our model, our forecast for S3 scenario is March 23rd. So it's only off by 1 day. And the total number of cases today, I think for Italy, actually the number was, I got from the website of WHO, is 110,000 cases. And our model forecast is about 127 cases, 127,000 cases. So it's also relatively close because the model was developed about 1 month ago. That level of model error is acceptable. We also forecast for Korea, and we did the forecast on the same day as the Italy model. We forecast on March the 9th. So we backtested for about 3 days, and we found that Korea's situation is very close to S1. So during the first half months of the epidemic, we found that the model performed very close to S1 scenario. After March 15th, we find that actually the number of new patients didn't decrease, which is a little bit puzzling to me. So I consulted Professor Kwang yesterday, and he confirmed that the new cases are mostly imported cases. So actually the model has performed very well in the first half of March, and would perform very well for the second half of March, excluding those imported cases. So a lot of my friends have asked me to make predictions about the US case. For US, the forecast is relatively hard because there's 50 states and Washington, DC. And each state is at a different stage in the curve. And each state have different testing policies. So on the right-hand side, we can say this is a test positive ratio for different states. The highest one is Hawaii, it's about 40:1. The lowest one is Michigan, which is about 2:1. And New York, I think the name is not shown here, but it's also very close to 2:1. As David just mentioned, in his hospital, the ratio is more like 3:2. So that's very alarming ratio. It means that a lot of the potential infected people are not tested. Also on the left corner, we retrieved this chart from CNBC on March 26th. It basically measures the restrictions for different states during the coronavirus outbreak. And yellow means that the highest or the most strict policy. And the light blue means that there's no policy at all. And the dark blue means that somewhere in the middle with no essential business closed, but there's no stay-home directive. Obviously, this chart is outdated because there has been new development of the case, and I think there's more strict state governments are enforcing more draconian measures. So we tried our modeling forecast for New York, and we found that under this difference, very similar to the previous model, we have S1, S2, and S3, and it seems that the New York model is somewhere near S1. So on one side, it's a good sign. However, if we look at the test ratio, it seems that the number of test cases on the right side, it seems that there's only around 20,000 tests performed every day. And the positive rate is about 50%. So again, it's a sign that there's not enough tests. And also on the left-hand side, I retrieved the data about hospital beds and ICU beds, which we do not have the exact number. So I kind of calculated the ICU beds based on the population and the US average level of 37 ICU beds per 100,000 population. It seems that even under S1 and S2, there's not enough ICU beds. And I didn't put the S3 scenario here because go way off the chart. Obviously, here we do not know exactly how many severe cases in New York, and I use about 10% ratio. The ratio is pretty wide. Even in China, in Hubei province, the ratio is about 20% severe and critical cases. Outside Hubei, it's about 10%. So it seems that New York definitely need to do more testing and prepare more ICU beds. Even the forecast for the whole US is hard. We still try to perform some preliminary forecasting. Although the stability of the model is to be tested. We did the test on March 28. So it seems that up till now, the increased number is still below S1, but the increasing rate hasn't slowed very much. So very likely it would go beyond S1 and reach S2. Under S1 scenario, the total infection number would be around 500,000. Under S2, it would be around 1 million. So based on the forecast right now, it looks like the final infection number would be around between 500,000 and 1 million. And also we did the same test. We did the same calculation for the test statistics. On the right-hand side, we find that all over US, the ratio is about 4:1. So it is higher than New York, but still it's much lower than some other countries. Like in Korea, the ratio is more like 25:1. And in China, the ratio is 8:1. But it's very different inside Hubei and outside Hubei. Inside Hubei, it's more closely to 4 to 5:1. Outside Hubei is like 30:1. So we believe to adequately test every potential close contacts, the ratio need to be around 25 to 30. We have read some news about there's new testing kits developed in US, and hopefully with the new testing kits, there could be more testing and more quick testing. So overall, I think we are looking at this situation, which is pretty dire. And I would like to share this poem from English poet John Donne to express my feeling. It's basically, it says, no man is an island entire of itself. Every man is a piece of the continent. Well, right now, every man is a piece of the world. So any man's death diminishes me because I'm involved in mankind. Therefore, never send to know for whom the bell tolls. It tolls for thee. Hopefully, we will work together and fight this coronavirus together. And I will try to do my best and share my models with other fellow researchers around the world. Thank you.
Yeah, thank you, Dr. Chen. And I just wanted to, could someone turn off that? Yeah. Okay, great. Again, thanks for Dr. Chen Jian. And all the PowerPoints and the slides and also video will be available. Hopefully, we will either post at the Brookings website or through our social media platform. people can also, welcome to contact us. We will be happy to send these PowerPoints to you. Now, let me ask a couple of questions for each of the panelists. Now, the first of all, for Dr. David Ho, as we know that the SARS-CoV-2, which causes coronavirus, novel coronavirus, is an RNA virus. The SARS-CoV and also HIV are also RNA viruses. Now, RNA viruses tend to mutate more easily, potentially leading to the deadlier or milder versions. Now, did this occur with HIV? How much should we worry about an even more dangerous virus causing a pandemic in the future? And what can the world do to prepare for or even prevent that possibility? David.
Well, the viruses you mentioned are indeed all RNA viruses, HIV, SARS coronavirus, and COVID-19. We know from years of research, RNA viruses generally have a high mutation rate, much higher than when our cells try to copy our own DNA. So the fidelity is much lower by 100-fold or 1,000-fold. So mistakes are made. One would think mistakes are bad, but when viruses replicate, it replicates by large numbers, and then by producing lots and lots of progeny and letting evolution take place, letting the fittest one survive. It does it by sheer numbers. Now, the mutation rate is actually also a molecular clock that allows us to see the changes, and then we could actually infer by backdating based on the sequence analysis. For example, we now know that by looking at the sequences of COVID-19 and comparing it with SARS and comparing with the like viruses in other animal species, particularly in bats, we now know that this virus probably is a recombinant form of two different coronaviruses. Probably that form took place not recently, but probably a couple decades ago, and residing in bat population and then infected humans. So I think we could dispense with the idea that some mad scientists engineered this for malicious purposes. But it also teaches us the fact that we have to be aware that these pandemics are zoonoses. That is, they are transmitted from animal species to humans. HIV was chimpanzees to humans. Ebola was bats through an intermediary or not to humans. And for both SARS and COVID-19, it's quite likely from bats through intermediary or not to humans. So we need to be aware of how the viruses behave.
Well, as a leading scientist on HIV, I wanted to ask you a question about the vaccine. Now, 40 years have passed since the outbreak of HIV. What was the reason an HIV vaccine never materialized? Could you comment on that? Maybe this is, early on you talked about the vaccine for coronavirus, but certainly, make us to think about the HIV virus, the vaccines. Could you comment on that?
Yes, HIV vaccine, as you said, is still lacking. It's not because of lack of effort or lack of support. In fact, it's now the holy grail of HIV research. But the short answer is the lack of a successful vaccine is because of the obstacles posed by the virus. The virus has a way of shielding itself at the external protein with lots of sugar, and that precludes very tight binding by antibodies elicited by our immune system. In addition, the diversity among HIV strains is so large that it's really hard. If you make a vaccine for one strain, it's really hard to cross over and protect another strain. It's basically these scientific obstacles that preclude vaccine development. I think we are not likely to face the same with SARS or with COVID-19 because we know we know. Could you hear me?
Yes, yes.
Okay. We know the structure and the similarities are not quite there. So we hope vaccine development for COVID-19 or SARS would be much easier. But we need to remember one thing, though. I think as scientists race to develop a COVID-19 vaccine, it's been reported in SARS that antibodies elicited by SARS vaccines in animals could be at times be harmful and cause more severe lung injury because of what we call antibody mediated enhancement. It is an aspect that must be resolved before we could move in an accelerated form into vaccine development and vaccine testing in humans.
Thank you, Dr. Ho. That's wonderful. Thank you for the very comprehensive analysis on that front. Now, I want to turn to Dr. Zhang Wenhong. Now, as the head of the Shanghai's anti-coronavirus clinical experts team, you are on the frontier of research and the treatment for coronavirus patients. Could you share with us about the drugs that China is used, including the use of Chinese traditional herbal medicine? I heard some of the stories. Could you comment on the drugs and also herbal medicine, Chinese medicine on that area?
Okay. Actually, China, we are the first Chinese team that using every kind of the antiviral treatment for this new virus, including lots of antivirals, the little Librevia and also the Abidol, and including recently hydroxychloroquine. And we noticed that lots of evidence that published by just like French colleagues, they published a paper. They announced that the hydroxychloroquine have very good antiviral efficacy in these patients. However, according to our experience, we compare every kind of the antiviral treatment. Actually, we did not find very significant difference between the different drugs. So according to our experience in China, I think up to now, we do not have any very strong evidence that for us to recommend any kind of the antiviral to treat the disease. So actually, we are waiting for the more evidence to help us to find the better drugs. So meanwhile, which is very, you mentioned that about the Chinese traditional medicine. So actually in China, we also used a lot of Chinese traditional medicine together with Western medicine. You know that China has used the traditional medicine herbs practice for thousands of years, long before the Western medications entered our countries. So therefore, Chinese doctors are very experienced in using it to treat the patients. However, in this pandemic in Shanghai, so not separately use Chinese traditional medicine or Western medicine. Usually, the doctors here would use the integrated strategy of combined Western and traditional Chinese herbs in treating the patients. So far, what I can tell you is that no strong side effects were observed in our patients in this during we treating the patients here. The efficacy of traditional Chinese medicine currently, I think, is very difficult for us to evaluate because we do not take the monotherapy of the drug to treat the patients. Therefore, I think in the future, we still need lots of some good clinical trial to evaluate the Chinese traditional medicines to evaluate the efficacy of the monotherapy or combined therapy compared with the monotherapy of the Western medicine. Therefore, we still need a lot of clinical trial to evaluate the efficacy of the Chinese traditional medicine and also the integrated treatment of Chinese medicine and Western medicine. Yeah.
Okay, great. I have another question for you, Dr. Zhang. Are you concerned about the spread of the coronavirus in low-income countries around the world, especially in sub-Saharan Africa? Is there anything that more developed countries and the international community can and should do at this point? I also welcome Dr. David Ho comment on that.
Okay, actually, during our meeting today, my colleagues in Africa, they give me some message about there's now recently there's some outbreak in Africa. So our team from China, so actually recently we have some colleagues now, right now, they stay in the Africa to help them to control the disease there. So actually recently in Sierra Leone, there's almost 7,000 cases were confirmed positive for the PCR. So therefore, I think there's a lot of crisis of the outbreak of the disease in some zone in the world with a poor medical resource. I think it's really very dangerous. I never concerned about the situation in Europe or United States. I think if we have enough time, both the United States and Europe will control the disease. However, if in Africa and the South Asia, I think maybe in the zone with limited medical resource, it will be a problem. The fundamental and the most crucial impact on the epidemics would be that country, I think with sufficient medical resources, just like the United States or China, we should cooperate together in the invention for the vaccine and the antivirals. I think the effective antivirals and the vaccine in the finally, I think will help the South Africa or the Africa and also the South Asia to fight the battle against the disease. So recently, actually, we noticed that the crisis is there already. So in the future, I think we still need the cooperation between the China, United States, and some other country with sufficient medical resources. We should help other countries to together. If the crisis in the Africa or just like India and some other countries with limited medical resource, if we cannot control the plague there, I think the world cannot be good. So in the future, I think it's very important for us to work together. Yeah.
Thank you, Dr. Zhang. Dr. Ho, do you have any comment about the less developed countries?
Yes, I am actually quite concerned about waves of the epidemic hitting some of those countries that you just mentioned. In India, in sub-Saharan Africa, in some of the South American countries, wave after wave, and given the resource poor setting, the surge in patients would undoubtedly be overwhelming for the healthcare system there. The other thing is some of those countries are in the Southern Hemisphere. And as the weather warms and become more favorable for us in the north to deal with, it will become worse for them to deal with as the weather cools in the Southern Hemisphere. And so we must bear that in mind. And I concur with what Dr. Zhang just said, I think the world better be prepared to help out in those resource settings, even though we are struggling with our own situation. And that's why earlier in my prepared remarks, I said we need to endure this together now and not wait. And some of those countries are not severely hit yet, and yet they need to endure with us and not allow the epidemic to take off. And they cannot relax just because the virus has not arrived at their front door yet.
Thank you. Thank you both. Now I turn to Dr. Chen Jian. According to the experts on the White House Coronavirus Task Force, the best case scenario, let me repeat, the best case scenario in the United States is that 100,000 to 240,000 Americans will die. You have applied your matrix modeling in forecasting both the infection rate and mortality rate in China. Now, could you comment on the forecast by your American colleagues working in the same area, including the very dire forecast just mentioned?
Okay, thank you for the question. That's a very important question. Let me step back. So let's take a look at the death rate. The final death rate in China is about 4%. But actually, inside Hubei and outside Hubei, the death rate is very different. Outside Hubei, the death rate is 1%. Inside Hubei, it's 4.7%. So why is so different? Because outside Hubei, we have a lot of medical resources and the health system is not overwhelmed. Inside Hubei, in the very beginning stage, it is overwhelmed. So the death rate is very high. And according to my numbers, in the very earlier stage, the death rate inside Hubei, the daily death rate from severe cases is 4% per day. But with a lot of medical resources, like Dr. Zheng Junhua's team, there's like 40,000 medical professionals. They went to Hubei and assisted, and there's new hospitals built like within 10 days, which can increase the ICU beds. The death rate eventually dropped very soon. And the final death rate of the severe cases on a daily basis is only about 0.2%. So that's like 20-to-1 drop. So I do not want to forecast the death numbers because that is not decided by the model. That is decided by how many medical resources are put into saving lives. But here, right now, in US, the current death rate is about 2.4%. Based on the number you just mentioned, that implies there's about 4 million to 10 million infected cases. Based on our forecast, we think it's not likely to happen. There's certain probability, but very small probability to hit that number. So I think right now, we don't need to concentrate on the number of death estimates. Eventually, it wouldn't be very accurate. What we need to know is how we can reduce this death rate. Thank you.
Thank you. Now, let me share with you some questions from our side, from people just sent in. Now, one question is for Dr. Zhang. Now, what is the estimated error rate in the test used in China to determine whether the person being tested is a confirmed coronavirus case? So in terms of, again, the question about the estimated error rate in China.
Okay. Actually, we in the first stage, in the first wave in Shanghai, we noticed that in some doctors in Wuhan, they mentioned that the false negative rate is very high for the PCR to detect the patient. I think it's very dangerous for us to cannot, for us, to miss the positive patients, and it will cause a spread in the community. Therefore, in Shanghai, we just test every kind of the kit, and we choose the best one to give the detecting for the patients. And every case, suspected case, we just do twice for the patient. According to our test, we found that if we will do twice for every patient, we will increase the sensitivity to almost 80%. So if the patient was highly suspected, just if the patient have the clue from the epidemiological area, and also have a very suspected phenomenon, or the symptoms, just like a CT scan, the phenomenon, sometimes we will do the third time for the PCR. So therefore, for more times of the PCR, we will decrease the false negative rate. And furthermore, sometimes in my lab, I will do the next generation sequencing for the patient. If we do more for the patient, the false negative rate will decrease to almost near the zero. So according to our experience in Shanghai, recently, we just find almost every patient we can find. Even sometimes we cannot find the positive of the PCR. We still quarantine the patient for 2 weeks. So therefore, even though sometimes the false negative PCR, we still have the experience for the quarantine for the patient. We still can avoid the risk of the patients stay in the community and stop the spread of the disease. So therefore, the false negative detection, it will not be a problem in Shanghai. Yeah.
David, do you have a comment? David, thank you, Dr. Zhang. Oh, we cannot hear you. Yeah.
Of course, I'd like to concur with, could you hear me now?
Yes, yes.
I concur with what Dr. Zhang just said. I think now we are gaining that testing experience a bit too late. Our current state of testing in America is sad and inexcusable. Our government sat on the sideline and dithered while watching China struggle in January and early February. But now, of course, PCR testing is increasing rapidly in the US. And as Dr. Zhang mentioned, the test is actually pretty accurate in general. But of course, collecting the sample is less precise. And if you don't collect from a good specimen, no matter how good the test is, it's not going to turn it up. In general, PCR is very, very sensitive. The other sad state of affair is that in the US, we are only just getting going with antibody testing. Those of us who are working in the field just assume US CDC had taken care of that, but no. And now we're doing antibody testing to supplement. And that's important because they measure different things. One looks for viral RNA and the other looks for body's reaction to the infection, and they should be using complementary form.
Great. We only have a few minutes left. This is another question from a medical professional in Bethesda, Maryland. The question is, in the worst case scenario, if we have neither an effective treatment nor a vaccine, we have to accept that eventually most people will be infected. What would be the best strategy to handle this situation to minimize the loss of life? Very quickly, maybe start from Dr. David Ho.
Well, I think that's the question we all are asking ourselves. I think we could flatten the curve, but as I said earlier, if we flatten the curve and don't have a permanent solution, the cases will continue to percolate through the community.
Okay, great.
Albeit at a much lower level. And that means we would have to change our way of life for a long period of time. We certainly need to I'm pretty confident that science will deliver, given the level of commitment that we're now seeing. So hopefully we won't be in that situation.
Thank you. Dr. Chen Jian or Dr. Zhang, do you have anything to comment?
Well,
we only have 1 minute left.
Very quickly, and different stage, we have to concentrate on different things. And this stage, we don't know how long it will take to develop the vaccine or antiviral. But things we can do now is massive testing, social distancing, minimize the probability of getting infected, and minimize the death rate. So that I think we can do. And I think Dr. Zhang have much more experience.
Okay, good.
Let him elaborate on that. Thank you.
Okay, Dr. Zhang, do you have?
Yes, I think so. This year, I think it's highly probable that we cannot get any effective vaccine or effective drugs to fight the disease. So therefore, our only hope that after this summer, we wish that the outbreak can be decreased to nearly zero. So, however, I think still, because there are now some vaccine currently in the phase 1 clinical trial. So under current situations, I think the optimistic guessing that the vaccine could be out maybe next year. So in my opinion, I believe that is also shared by many of my fellows that vaccine development should be definitely needed in the end. The reason lies that the current global pandemic still see no ends, and the assumption of the persistent transmission COVID may not too wild a guess. Okay. For countries that less prepared or with less healthcare resources, the vaccine might be, I wait for that. So even though you think maybe we will not have vaccine, but actually we still need the vaccine to end the battle. Okay.
Okay, great. Now, as we near the end of this almost 3-hour-long webinar, I would like to take a moment to thank everyone who helped bring together today's event, including first and foremost, you, our audience, without whom these urgent lessons could not be shared and implemented in communities around the world. Many of my Brookings colleagues, especially Ryan Haas and Ryan McKinley, who planned and executed this logistically complicated event. Media platforms across North America, Europe, and Asia that have live broadcasts and amplify this discussion to a much wider audience. And last but not least, our speakers, and whose experiences and advice are invaluable to so many who are on the front lines combating this formidable virus as we speak. Now, the fact that most of our speakers are based overseas, mainly on the other side of the Pacific, reflects the imperative for international cooperation. In confronting global challenges like this, we all benefit from pooling our resources and sharing our wisdom and ideas. We are inspired by your participation, which symbolizes the conviction in and the commitment to our common humanity. With that, we conclude today's program. Stay safe and well. Bye.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.